Thank you.
Yeah, thank you very much, Anja. Yeah, welcome. So I would like to talk about something that is very important, the resistance of antibiotics and how we can actually kind of mitigate the risk that we will have more and more of those resistance. In 1945, Alexander Fleming received the Nobel Prize for the discovery of penicillin. Actually, it all happened, with an incident in his lab. He had some petri dishes with bacteria he was working on, went for a brief holiday, and when he came back, he found that on some of the petri dishes, a mold had developed. Where this mold had developed, the bacteria were actually dying. That gave him the idea that this mold, so this fungi, would actually create something, some toxins would actually interact with bacteria, and that it is maybe something that could be developed in a new drug. And together with his co-collaborators, Forey and Chain, he received the Nobel Prize in 1945 for this discovery. But already then, so when he had discovered that, he was aware of that there could be resistance because bacteria are proliferating very fast if the drug is not used in the right time and with the right level. So he was very concerned about that, and it happened to come and be true, and now is a big problem which we have to tackle. Let's look at that. What has been the time before and after the discovery of antibiotics? And it cannot be overestimated how this has changed the world and how it's changed medical sciences. If you look at that, it's just mind-boggling. The average life expectancy before the discovery of antibiotics was around 47 years. After the discovery of penicillin and antibiotics, it increased by a mind-boggling 30 years to a life expectancy around 79 years today. Unfortunately, we see already resistance coming up. So our sharp weapon of antibiotics becomes blunt. And it's estimated that by 2050, people may be more likely to die of infectious diseases because the antibiotics would not work than of cancer. And that is called the medical climate crisis. It would also lead to a massive reduction in the gross product of the world democratic product by 2 to 3.5% if we don't are able to tackle this crisis. And in the COVID pandemic, one thing we also have seen, there was a lot of antibiotics being prescribed to patients indiscriminately, precautionary, but that reduces the window of opportunity further because it creates more resistance, and the patients coming out of the COVID might then otherwise suffer from antibiotic resistance and bugs that could be superbugs. Now, what are we concerned about, and why is it so important actually to treat the patient in the right way and not only give antibiotics indiscriminately? So we have to think about the patient himself. It must be the right patient. The medical history plays a role, the surgical history, and the antibiotic history of the patient is very important when you prescribe antibiotics. Then you need to also find the right diagnosis because you need to know what is the bug, the bacteria that causes this illness, what type of infection, what type of hygiene and origin. We need to also think about the right dose. Antibiotics have to be dosed in the right way so you can overdose or you underdose. So you need to figure that out. And you need to include those information you have from the hospital, from the World Health Organization, or from UCAST. And when you give the antibiotic, the duration is also important. Too many patients, feel good again. They stop the antibiotic treatment by themselves, although the doctor has prescribed it. And what happens? The evolutionary pressure on the bacteria is receding, and bacteria become resistant. Then we also have to think about what is the pathogen we are talking about? What's the bacteria that is causing the illness? We need to think about the antibiotic itself, the right spectrum. There are broadband spectrums and very selective antibiotics. So this is very important to think about it. The right drug, thinking about resistance and about the right drug that it could be, prescribed for this particular infection. Also, allergic factors are important to think about here. And in the end, the question is, should it be administered orally or should it be administered through intravenous injection? Now, why do bacteria become resistant to antibiotics? Well, there is a mechanism in bacteria. They grow very fast. They have the ability to exchange gene material. Even if they come close, they can exchange the gene material. There are spot mutations, and that all creates very rapidly resistance to antibiotics. Then, when you look into the situation in hospitals or in places where antibiotic and where the bacteria can be found, you can acquire it through the ventilator. You can acquire it in the hospital. So there are site-specific resistance, which is very scary. And you have heard about superbugs in hospitals spreading. And then we also have to think about the person itself, because bacteria is interacting with the microbiome of the person in a very complex way. And when we give an antibiotic, we don't want to kill the good bacteria, which are part of your microbiome, but we want to target the bad ones, which are causing the infectious diseases. Now, what we have created is, we have created a knowledge graph where we integrate the knowledge about symptoms, diseases, infectious diseases, so that we can find out what is the right disease we are talking about. This is a belief knowledge graph that maps the symptoms and those disease information. We have the disease ontology. On the other hand, we have the information about the bacteria, about resistance, which is already known, about bacteria in these categories: aware, watch, and reserve, and the antibiotics that are being reserved. And here we can actually help the doctor in the prescription process to guide them to administering the right antibiotic. How does it look now? When we look into this, we'll see that these two graphs, which we have mapped to a Neo4j database, graph database, includes this enormous knowledge, medical knowledge, which is already there about symptoms, diseases, gene and symptoms interrelationship, resistomics, patholomics. That is the belief knowledge graph. And on the other side, to administer the drug, we have different ways how to guide through the clinical pathway, so to help the doctor to prescribe the right antibiotic here. And this is the system, and we will show that in more detail. My colleague Ashoka will guide you through that. It shows you a typical scenario for that. The patients come in, will complain about some symptoms, having fever, having night sweat. This type of symptoms is automatically interpreted. It's mapped to a controlled vocabulary. And this controlled vocabulary, using standards like the International Disease Classification System, it becomes machine interpretable. Then, based on this, diagnosing the right infectious disease, now the antibiotic that would be most effective will be suggested. And this antibiotic then can be administered either orally or through intravenous injection. What we need to think about is the right care at the right time, at the right price, at the right point of care from anywhere, avoiding antibiotic resistance because we give the wrong antibiotics and we give the wrong antibiotics during the wrong duration. So this is the point where, Rust reiterating the 6D model of antibiotic stewardship, right diagnosis, right disease-causing agent, very important to figure that out, and then clearly giving the right drug, de-escalating that by giving the antibiotic which is most suitable for the illness, in the right dose and the right duration. I hand over to my colleague Ashoka.
Yes, thank you.
If you can see my screen, I will now offer the demo. As Roland has just said, is that we have right now the digital twin and the digital triplet. Digital twin is the reflection in the digital world of the real world, whereas the digital triplet is an abstraction of the real world into once again in the digital world. But the difference between digital twin and the digital triplet is that digital twin is the one-to-one mapping, whereas digital triplet is an abstraction of the real world into the digital world. And I will take you through that. Say, for example, now, and this is I'm going to show right now, is the digital twin of a physician. When a patient is having some kind of chief complaints, then he goes to the doctor. And in this case, I've taken fever, which is one of the most common one. And we can find out that there are 474 diseases which are associated with fever. And these are some of the areas where there are a lot of, misdiagnosis. Now I add few other symptoms or chief complaints. Along with fever, we have night sweat, and along with night sweat, we have given coughing blood, and then we have also given hemoptysis. Now, here, what we see is that when I'm giving multiple symptoms, it has come down to 3 diseases. That means these 3 diseases have those symptoms or the conditions in common. And on the right here you can see those are human understandable English in natural language, where I said fever, night sweat, coughing blood, and hemoptysis. Now, hemoptysis and coughing blood, hemoptysis is understood by the doctors, whereas for common people, coughing blood is much more understandable. But you can see on the right where this human understandable natural language through a artificial intelligence engine has been converted into machine understandable code. And here you can see that it has given 3 diseases: pneumonia, heart cancer, and tuberculosis. Now, heart cancer, many doctors will miss it, and what they are likely to do, they are likely to predict as tuberculosis and do the treatment for that. And we have the detail, and you can go here, heart cancer, which says the symptoms are hemoptysis, then fever, and then night sweat. So you get that in a moment in front of you. The chances of error is less. Pneumonia is a infectious disease. So now I will show you the digital twin of a microbiologist from the knowledge graph. So what we are trying to do is that we are mapping the human mind and human brain into the knowledge graph. And here, when I click pneumonia, Roland talked about the right diagnosis. So from the symptoms, we did right diagnosis. Now the question is that we need to identify what is the right disease causing agent. That is, what is the bacteria causing this particular disease. As I said, that 26.5 million antibiotic courses per year given to patients who are not having tuberculosis. And the patient number is 5.3 million patients per year. And here you can see the disease-causing bacteria are those, and we can see on the next column what are the antibiotics resistant to this particular bacteria. So that means if we use any of those antibiotics for this bacteria, then they will be resistant and it will not work. Or for example, Streptococcus pneumonia. These are the drugs which will not work. And here you can see what is the digital triplet. And digital triplet, as I said, here there are 2 abstractions. One is the microbiomes, which you can see, microbes, and then the diseases, infectious diseases. And here, what is very interesting is that, as I said, that in this abstraction, we can find out unknown knowledge. Let me repeat. When we are talking about digital twin, what we have is that we convert the real world into digital world, and we can find out what are the hidden knowledge. Practically in human brain, those are called tacit knowledge. So we convert tacit knowledge into explicit knowledge and store it into the Neo4j database or the Neo4j knowledge graph. And here you can see the infectious disease, which are in this space very close to pneumonia, which is meningitis. And practically, as a matter of fact, Streptococcus pneumonia, when it goes to the bloodstream, then it is likely to affect the brain and cause meningitis. So for a doctor, this is, for many doctors, this is an unknown knowledge. And then what we do is that, and here are some of the, here is, I just talked about Streptococcus pneumonia, and these are the antibiotic. I'm just showing you in the Neo4j knowledge graph, the cipher comment here, which fetched all those things. Now, while Roland was talking, he talked about intrinsic resistance. Intrinsic resistance happens due to the gene transfer, and when it is a permanent resistance that cannot be changed because it is now genetic. But there are another type of resistance which he talked about is site-specific, which are specific to hospitals or within a hospital, a clinic, or even it could be an ICU. So here, from the ICU data, we have taken the antibiogram data, which are sensitive to the culture data. And here, what happens is that in that, what we do is that we take the culture data, and from there we did Bayesian probability network, and from there we have organism, and there are different antibiotics which may not work, which is not a intrinsic resistance, but this is an acquired resistance in a particular setup like community acquired pneumonia or ventilator associated pneumonia. Okay, there are quite a few number of people when they are in ventilator, they acquire pneumonia from the hospital itself, from the ICU or from the ventilator. So this is a probabilistic graph where we have that. And here is an example of the result is that here I have given that for this antibiotic in the hospital ICU, which antibiotics are likely to be resistant and likely to be susceptible. So here it says that Serratia is 100% susceptible. So it is better. And this is a data from pediatric ICU in one of the tertiary hospitals in India, where we have the, okay, and here is the antibiotic stewardship. Antibiotic stewardship is, now this is about precision antibiotic therapeutics. So what we do is that here there are few cases to make sure that we don't underuse or overuse antibiotic. So here it is a COVID case, and we have in the knowledge graph the evidence. And here the evidence says that this particular antibiotic should not be used. You can see it here in the interpretation. Our findings do not justify the routine use of azithromycin. So what we do is that we provide the, and then the stewardship committee, they reject this. No, it should not be used. Then there is another case where we have a case where somebody has offered a broadband, a antibiotic which is of broad spectrum. So here we are trying to change, looking at the evidence, we change the antibiotic to a antibiotic which is likely to cause little harm. And that is why we are calling it precision antibiotic therapeutics. And then the doctor, he approves it. Okay, so the point is that when it comes to the stewardship committee, they go through each and every antibiotic prescribed, and then see whether we can reduce the broad spectrum to a narrow spectrum, or can we change it from intravenous or intramuscular to oral, because all those things will reduce the chances and possibilities of this particular bacteria becoming resistant to some drugs. Okay, so here it is, after changing the drug, the recommendation, it is getting approved. The last one is a 2-year-old patient, a child who is having pneumonia, and here it says that for this particular, a broadband is sufficient, and then we approve. So this is approved. So what we try to demonstrate here is that we have shown the digital twin and the digital triplet of a doctor's mind, where we do the right diagnosis, and then we went to the digital twin and the digital triplet of a microbiologist's mind to show that for that infectious disease, what is the disease-causing agent? And for that disease-causing agent, what are the right bacteria to be used? And if you see here in this, we are also talking about IV DDD. DDD is defined daily dose of that particular medicine, which is recommended by WHO, and whether it has any oral substitute. If yes, in this case, for the first one, there is no oral substitute, and what should be the day of the therapy. So we offer all those information to the physician or the practicing doctor at the point of care, so that the chances of error is less and the antibiotic resistance is controlled. Thank you.